Welcome, everybody. Hi, my name is Beth Stronach, and I'm here with Resopathies Network. We are a nonprofit organization, and we advocate on behalf of individuals with Resopathies syndromes, which are genetic conditions of the RAS pathway. Our mission is to advance research to improve the quality of life for individuals with Resopathies by bringing together families, clinicians, and scientists. And we primarily do that in two ways, which I will get to in just a moment. So what are Resopathies? First, they are a collection of genetic syndromes. And second, they have a similar clinical traits. So you may go to the doctor and you get a clinical diagnosis. And then if they try to find the cause of that, the health problems that you're having, they may find that it's linked to one of these genes or proteins shown in this sort of cartoon pathway. So this is supposed to be a cartoon of a cell in your body. And inside the cells of your body, they send lots and lots of messages. And so aside from the dotted lines here, which link the syndromes to the genes or the proteins, these little circles indicate some of these RAS pathway proteins, and they're really messengers. They're like messengers running a relay inside your cell. And in the Resopathy syndromes, some of these mutations cause those messengers to either run too fast or to send messages when they're not really supposed to. And so this pathway gets activated, and that's what causes some of the symptoms or the traits that you find in individuals that have Resopathy syndromes. So what are the syndromes? Noonan syndrome and some of the Noonan syndrome-like disorders with loose anagen hair or with multiple lentigines, Costello syndrome, neurofibromatosis type 1, cardiofaciocutaneous syndrome, CMAVM, which I'm blanking on the CM part, cutaneous malformation, arteriovenous malformation syndrome, and Legius syndrome. So these are, some of them are fairly rare, some of them are fairly common, but essentially we are linked by the overlapping syndrome features that we have or that our loved ones have, and we're linked molecularly by this pathway inside cells that really is like sort of a text messaging system that controls how the cells behave. So our organization is really interested in trying to advance research on this particular pathway so that we can improve the quality of life for individuals with this syndrome. Our board members represent the different syndromes. We're volunteers, and we have children with these syndromes. Our names are listed here, and we provide a voice for those with those syndromes. If you're interested in becoming involved, please contact us and we'll have our information at the end. So how do we advance research? We try to do this in two different ways. One is that we hold biennial symposia, and we have one coming up this summer in Denver, July 21st through 23rd. And it's going to be our 8th international symposium. We will have people attending in person in the city of Denver, and we'll also have a virtual option. So please join us, take a look at the agenda, which I have the URL link above, and we're going to be touching on a bunch of different topics over the 2 to 3 days. So please go to the website to find out more information. Families are welcome. We will be sort of having collaborative discussions with researchers, scientists, clinician scientists, doctors, and genetic counselors, anybody who has a stake in how these diseases are treated and researched in the future. Our second campaign is really to support research by raising money for pilot grants. And we do that through infrastructure provided by the Penn, University of Pennsylvania Orphan Disease Center. So they have a $1 million bike ride every single year. This is the 10th anniversary, and they allow Resopathies Network, as well as many other rare disease groups, to do a really fun bicycle ride and raise money. So this year it's going to be held on June 10th. Some of us are going to be there riding in person. You can ride virtually or volunteer at the water stop. And if neither of those sound good, we would also ask that you support or advance research through this mechanism by donating whatever you can. So we appreciate your support in the past. We've been able to support nearly $500,000 worth of individual projects. Some of those are shown here, touching on all kinds of different systems and science. The asterisks represent the folks who are actually going to be at the symposium giving talks, so you can hear about the progress that they've made with this pilot funding. And our latest awardee is Dr. Joe Streisma from Radboud University Medical Center in the Netherlands, and he's doing a project to look at central lymphatic system issues in adults with rhesopathies, Noonan syndrome and cardiofaciocutaneous syndrome. So that's our 9th funded project. We'd love to have your support for our 10th funded project, which is will be announced obviously next year once the bike ride has taken place. So with that, I'll thank you for your attention. As I said, you can always contact us, let us know what webinars you might be interested in, or if you're interested in helping out with the organization, providing content, or just asking us for information. Our email is there, info@rhesopathiesnet.org. So thanks for listening. And at this point, I want to turn it over to our main attraction. We want to hear from Dr. Andrew Dauber, Chief of Endocrinology at Children's National Hospital. Dr. Dauber was kind enough to give us an update on his clinical research using Vosoritide for growth in Noonan syndrome and other rhesopathies. He spoke to us once before, and now he has some details that I think he can share. So we're really happy to have him back. And I can stop sharing my screen now, and you can share yours and take it away. Thanks for being here.
It's my pleasure. And, I just really want to thank thank Beth and Lisa for the opportunity to join you guys, and really for all of your work. It is such an important partnership to have between, the researchers and the patients and families that who are affected by these various conditions. And it's really amazing what you guys do. So thank you for having me back. And I'm happy to share some updated information. Some of these slides nobody has ever seen before, so they're hot off the presses, so exciting. I'm going to share you the most up to date of where we are in our current clinical trial. So I'm talking about Vosoritide. I'm going to tell you a little bit more about that. It's a medication focused on helping the short stature, which is a characteristic feature of many of the rhesopathies. And this is an investigator-initiated study, meaning that I and my colleagues at Children's National designed and wrote the study, but it is funded by BioMarin, who is the company that makes Vosoritide. And these are my disclosures. And as I said, BioMarin is funding this particular study. I do not receive any personal compensation and never have from them. So when endocrinologists traditionally have thought about growth disorders, they were really focused on growth hormone, right? So for many years, we learned that the pituitary gland, this gland that sits right under the brain, it makes growth hormone. Growth hormone goes to the liver, which produces another hormone called IGF-1, insulin-like growth factor 1. And both growth hormone has direct effects at the growth plate, and through IGF-1, it goes to the bones. And there's this area in your bones called your growth plate, where there are cells that help make your bones grow longer. And as hormone doctors, this is really what we learned about and what we thought about. And I would describe that over the last 40 years, probably, since recombinant human growth hormone was first made in the mid-1980s, I think that there are kind of two stories or adages that aptly describe the diagnostic and therapeutic approach in the growth hormone era. And this applies, I think, to many rhesopathies as well. And that approach, here's the first story, right? So there's a man who's down on his knees on the ground on the sidewalk. And another man walks by and he says, "Hey, Did you lose something? Can I help you out? And the first man says, yes, I dropped my keys. I can't find them. So the second man says, well, where did you drop your keys? I'm going to help you. Is this where you dropped them? And the first man says, no, actually, I dropped them down the block over there. So the second man's puzzled and he looks at him and he said, well, if you drop them down over there, why are you looking over here? And he said, well, this is where the light is, right? So for many years, as endocrinologists, we learned a lot about hormones. We learned a lot about the growth hormone pathway and thought that this was the major and only player in growth. And we really didn't know a lot about the RAS pathway and all of the other players that are involved in affecting cell growth. So therefore, we looked at everything, through this eye of, are the patients making enough growth hormone? Is growth hormone working correctly? Is that where the problem is? And of course, the second adage is, when all you have is a hammer, everything looks like a nail. And our only therapeutic option for many years was growth hormone. And I'm focusing on the stature component. But in recent years, we've started to learn a tremendous amount about genetics and about the pathways involved in growth. And on the left here now, you see a cross-section through a growth plate. You can see those columns of cells called chondrocytes. Those are the cells that line up, they replicate, proliferate, and then they get bigger and they start secreting stuff, which in the end is going to form new bone and make the bones longer. And on the right, I've zoomed into one of those chondrocytes to focus on some particular signaling pathways. And if you focus in right in the middle, kind of in the top to the right, you see RAS there, RAS, RAF, MEK, MAP kinase. That is one of the most important signaling pathways in the chondrocyte that affects how it's going to grow, how it's going to replicate, and how it's going to make your bones longer. And in the top right, you see another thing called CNP. CNP stands for C-type natriuretic peptide. And CNP binds to its receptor, and through its signaling, it blocks the effect of that RAS pathway. So the RAS pathway, when it's turned on, it's like a brake. It's telling the cell not to grow, right? Not to get bigger, not to make your bones longer. And CNP comes in on the side there and it lifts up that brake. It says, no, cell, go ahead. We can stop that signal and we can help you grow longer. At least that's, one of its jobs. Now, the RAS pathway is much more complicated than what I showed on that first slide, and probably much more complicated than this review, which was from 2018. But you may notice on this pathway many of the different genes that are involved in causing the various RASopathy spectrum. In the left, in the blue area, you see PTPN11, the most common cause of Noonan syndrome, not the only by any means. You see neurofibromatosis, NF1, towards the top right, but they all feed in to this RAS, RAF, MEK, ERK pathway that I showed you, right? That is the downstream, we call it it all funnels down to this pathway, which is where CNP is going to be active. So back in 2000, now over 20 years ago, a group at the National Institutes of Health were trying to learn what were the functions of CNP, and they took cells from rats, from the growth plates of rats, and they added on CNP, and they showed that if you add more CNP, it makes those growth plates grow faster in a petri dish. And they saw that it increased the amount of chondrocytes in a certain zone, how big they were, and how much of that kind of goo in the growth plate that they were making. And taking advantage of this, fast forward 20 years now, BioMarin developed a drug called Vosoritide, okay? And Vosoritide is a medicine that acts just like CNP, but it has a little bit of a longer, what's called half-life, meaning that it stays in the system for longer than just regular CNP, okay? And they developed this drug to target achondroplasia. So achondroplasia is the most common form of dwarfism. It's what many people picture in their minds when you hear of somebody with dwarfism. Okay. So they were targeting this as the initial group of patients who may benefit from a CNP therapy. So just going back for a second, going back to our cell in the top left, you see FGFR3 in pink, that receptor. That's the receptor which, when turned on, certain mutations turn on, it causes achondroplasia or hypochondroplasia, which also activates that same RAS, RAF, MEK, MAP kinase pathway. All right. So they thought that CNP treatment could work for that as well. And they went through the various phases of trial. And most recently, this is the phase 3 study published in 2020, showing that in a randomized, double-blind, phase 3 placebo-controlled trial, Vosoritide was able to cause kids with achondroplasia to grow faster than those who received a placebo. And they grew on average around 1.5, 1.6 centimeters per year faster than those who were receiving placebo. And based on this data and some other data, last year, the FDA approved Vosoritide. Its brand name is Voxzogo. They approved it for use in children with achondroplasia. So this was the first and only so far approved targeted medicine for children with achondroplasia. And achondroplasia has a lot of medical complications associated with the poor bone growth. And the hope is that over time, this medicine will not only make people grow better, but could also help prevent some of those important medical complications. So I approached BioMarin now a number of years ago, probably close to 5 years ago now, and said, you know, this medicine should work for other conditions as well, not just for achondroplasia. And I gave them a proposal that I wanted to use it in other conditions as well. And they said, sure, let's go for it. And I, negotiated with the FDA, and we finalized on 6 different genetic causes of short stature, or categories of genetic conditions that cause short stature, to include in our study. So one was hypochondroplasia, which is the milder form of, mutations in FGFR3, similar to achondroplasia. One is in individuals who are missing CNP itself. We haven't found anybody like that. There are only a few in the world who have ever been reported, but logical candidates for a CNP replacement. Another is people who are missing or have a mutation in one copy of the receptor for CNP, which is actually a relatively common, rare cause of short stature. The next is not just Noonan syndrome, but the entire category of restopathies, because as I showed you, they all feed into this pathway. Many of them have short stature and poor growth associated with them. Mutations in a gene called SHOX and in a gene called aggrecan. I won't go into the details of those today. And as evidence that this may help, we to kind of show the FDA that there was logic behind doing this, besides just, here's where it hits on the pathway. There had been some animal studies done in the past that suggested it might be helpful. So in a mouse model of neurofibromatosis type 1, what this shows is that when you kind of were able to give more CNP, have the CNP levels be higher in those mice, it was able to increase the growth of the mice with neurofibromatosis. And when you looked at their growth plates, it kind of normalized the way the cells were growing, in their growth plates. Very similarly, there's a mouse model of cardiofacial cutaneous syndrome with a mutation in BRAF, which is the classic gene that causes that. And again, similarly, the mice grew much better when given the higher doses of CNP. And it was, again, able to kind of rescue that growth problem in those mice with cardiofacial cutaneous syndrome. So there was good reason to suggest that this medicine could be helpful. So we designed this study initially just targeting 35 patients, although now we're going to recruit up to 70. And these are the inclusion criteria for the study. The kids have to be at least 3 years old, and that's so that we can get accurate standing measurements in them. And less than 11 for males and 10 for girls. They can't have started puberty yet. And they have to have a height below this certain cutoff, minus 2.25 standard deviations. Because as many of you may be familiar, there's a wide spectrum of the degree of short stature that's seen in individuals with certain riskopathies, and many of them don't have short stature. So we wanted to make sure that if we're going to expose them to the medicine, that there's some potential benefit for them. They have to have a normal body mass index, not be underweight. They have to have a documented mutation in one of those categories, and essentially otherwise, not have significant medical issues that may impair their growth. The most relevant for today's discussion is to be on the safe side, because this medicine, as I'll show you, could lower your blood pressure a little, although it hasn't really been causing any problems with that. We excluded patients with certain heart disease, including hypertrophic cardiomyopathy, as we wanted to make sure we were doing this safely. When we first launched this study, this medicine had not yet been approved, so it was still very much experimental, and we wanted to be as cautious as possible. And patients must live in the United States for the duration of the study. And we have had patients relocate actually from multiple different foreign countries to participate in the study. We're the only site at Children's National, we're the only site in the world that is currently conducting the study. So the way the study works, it's an 18-month study. The first visit is the screening visit, where we just take measurements. We do an echocardiogram, an ultrasound of the heart, some blood tests, medical history, and then we observe for 6 months without the medicine. So we can get an initial baseline growth rate for each individual patient, because everyone's different. There are different conditions, different mutations. We need to kind of know where they're starting. And then we start them all on Vosoritide. So Vosoritide is given as a daily injection just under the skin, very similar to growth hormone, tiny needle. And it's something that you would do at home. But that first day, we give them the medicine. Patients stay all day just to make sure nothing goes wrong. We check the drug levels. We do a whole bunch of other tests. We do an X-ray of their hands called a bone age, an X-ray of the spine, a bone density scan. Then you come back the second day, and one of the parents actually gives the medicine after we've taught you how to do it. And there are no blood draws or anything the second day. We just watch for 2 hours. And then patients, you guys go home. We check in with you via the phone very frequently. You come back for 6 months for a check-in, and then at the end of 12 months. And we've now been approved for an extension phase of the study. So patients, individual kids who are responding well to the Vosoritide are then eligible to continue on it until they're done growing. The primary outcomes, the things we're looking for, is one, safety. Are there any adverse events that related to the medicine that we're finding? And then we're looking at how much this affects their growth based on their growth rate and their height standard deviation score. We're looking at body proportions. We're looking at their maturity of their bones on X-ray called their bone age. And then we're also doing a whole bunch of drug measurements for pharmacokinetics, pharmacodynamics. We're looking at quality of life surveys and bone mineral density as well. So here's where we are in the study right now, or as of a week or two ago. I'm missing, I think, one person on the left. So there are approximately a little bit more than half of the individuals in the study are males. And we currently, as I said, 42 people, 26 of whom have hypochondroplasia. But we have 5 with Noonan syndrome, 1 with neurofibromatosis type 1, and then 5 each with those 2 other gene mutations, the aggrecan and NPR2 gene mutations. So 6 patients with riskopathies who are currently in the study. And these are, I'm just going to focus on those 6 for today because they're most relevant to your group. These are the 6 people, who have breastopathies. As I said, 5 have Noonan syndrome, all of whom have mutations in PTPN11, which is not surprising. Their ages range from a 3-year-old, a 4-year-old, a 5-year-old, a 7-year-old, and an 8-year-old, and then one 6-year-old with neurofibromatosis type 1. And on the right, you can see their height standard deviation scores when they started in the study. So all of them are below the curve, which is an inclusion criteria in the study, but ranging in the degree of severity. So here's it is. This is hot off the presses, the most up-to-date data on how people are doing with the medicine. And I will first warn you that this is a very small number of people, right? And that there's always going to be some variability in measurements, and always people tend to, on any growth medicine, do best in their first year. But what you can see is 3 of the patients we have now who have not only been through the observation period, but actually have been on the medicine for at least a year, and all of them are continuing on it. So those 3, you can see the one in the greenish color was initially growing at around 2.5 centimeters a year, which is like 1 inch a year. And in their first 6 months went up to close to 10 centimeters a year. And then if you averaged it out over the year, close to 7 centimeters a year. So that kid was growing an extra 2 inches a year at that rate, which is a phenomenal response to therapy. Similarly, the one in blue went from around 4 to 10 centimeters a year. That's also more than another extra 2 inches a year. In the second year, it slowed down a little bit, but still growing at least an inch a year more than was without the medicine. And our third patient, the red patient, was growing at a pretty good rate to start out with. I think that's because that was one of the younger patients to start out. And now is growing also more than an inch extra per year. So really very encouraging and exciting initial results. But again, this is 3 people, the only 3 people in the entire world who have gotten Vosoritide who have Noonan syndrome. But encouraging preliminary data. And if you look at their height standard deviation scores, you can see that so the first point is at screening before they're on the medicine. And then that first line until day 1, they have not received medicine. So you could see that the lines either stay pretty flat or go down. And that's because they were not catching up at all without the medicine. And then you can see with the medicine, they are all over time catching up and getting closer. And that first patient in the red moved from below -2 standard deviations, is now all the way at -1.5 standard deviations. So well within the range, the average range of the general population for people who do not have Noonan syndrome or osopathy. And you can see that the blue line, that child has continued to show catch-up growth and is going from close to -4 standard deviations all the way now to -2.5. It's much closer, and is continuing on the medicine now and has been on it for more than 2 years. The other patients have not come back yet on the medicine, so we just need more time, and we'll see what happens. From a safety perspective, overall, it has been very well tolerated. It is extremely common to have some injection site reactions, meaning just some very mild redness or pain or swelling or even a hive at the site of the injections. They often last for seconds or minutes, rarely a little bit longer than that, but nobody has stopped the medicine because of any injection site reaction. We haven't had any episodes of low blood pressure with symptoms associated with it, but in general, the whole population of people treated with Vosoritide, that can rarely happen. And as a precaution, we tell people to eat and drink before they take their medicine so that they're well hydrated. Just to go over a few study logistics, these questions often come up. It does require, for those initial 18 months, 4 visits to Washington, D.C. We make all of your travel arrangements and cover the costs for the child and one parent. So pay for your flights, hotels. We give you $50 per person per day for food and all travel costs. We don't pay people to be in the study. The goal is not to induce people into being in the study based on compensation, but we want to make sure that people don't have financial barriers to participate in. And then, as I said, if people are having a positive response, which so far all 3 individuals who reached 1 year with Noonan syndrome have, then you're eligible to enroll in the extension study and continue on in the study. We continue to cover the costs. This is a research study. It is 100% voluntary, and you may change your mind and withdraw at any point in time with absolutely no penalty or upsetness or anything. This has to be right for you and your family. So that is always true, both in the initial study and in the extension study. And results were very, as you can see, transparent. I feel very strongly that these are partnerships and that the people who are involved are giving of themselves, so you have access to your information at all times. And we will, when we publish stuff, we'll share it with obviously everybody who has been involved in the study. I realize I left off an important question, which is going to come up, which is that kids cannot be on growth hormone during the study. Okay, so for the duration that both the observation period and the period you're on Vosoritide, they cannot be on growth hormone. It is fine if you have previously been on growth hormone. So some of our patients have been on growth hormone and have not felt like they were getting a good enough response, and therefore have stopped growth hormone and then enrolled in the study. And you just need to stop it like a few days before. And that is 100% fine. And is often a reason people would go in. But you can't be on at the same time, because then this still is a study to prove whether the medicine helps or not. And it's hard to know if Vosoritide is helping if somebody's also on growth hormone. The benefits, this is a study primarily focused on growth. Okay, we are looking at bone density. We are asking questions about quality of life. We're looking at other things. We are doing ultrasounds of the heart. We're looking at all of those things, but the primary outcome of the study is to focus on stature. Okay, so not for those other things. The risks, as I said, so far it seems like a very safe medicine. The injection site reactions to low blood pressure are the major risks. Those are the risks that are on the FDA-approved label as well. So in conclusion, so far Vosoritide is very well tolerated with a similar safety profile to what's been shown in the now hundreds of patients with achondroplasia who have received it. Our preliminary results suggest a positive response in actually multiple of the subgroups, but there is definitely variability between people, and we are very excited about our initial response in the patients with Noonan syndrome. But I am cautious. I don't want to mislead anyone. These are very small numbers of patients, right? And this is very early days. So we do need more patients. And actually, that's why, as I showed up front, we initially only had 35 patients in the study. When we hit 35, because we had so many more with hypochondroplasia than the other groups, we went back to the FDA and said, we'd like to stop recruiting for hypochondroplasia and just expand the other groups. And they said, everything looks fine, go ahead, keep going, no problem. So that's why we now are continuing to recruit and expand those other groups of conditions. And again, I only focused on the restopathy ones today. The reason I didn't show any data with the one patient with neurofibromatosis type 1 is that she just started on Vosoritide, I think 3 weeks ago or something. So I just don't have any data yet on her. Just to sum up for you, because even if it's not this study, I am really excited about the major advances in our knowledge of genetic mechanisms underpinning growth disorders leading to short stature, and restopathies, I think, is an absolutely beautiful example of how much has been learned in the last decade. Like the molecular basis for many of these conditions, like nobody knew, until the last decade or so. And that understanding the biology, has really helped us get beyond just thinking of, is this growth hormone deficiency or not, or how's growth hormone working? And it's letting us start to actually come up with ideas of precision medicines that are targeted to the exact pathophysiology. And based on our preliminary results, we think that any genetic condition that leads to this increase in that ERK phosphorylation, which is the end of that RAS pathway, or there are lots of parts of the RAS pathway, end of one of the parts of the RAS pathway, that they may be responsive to Vosoritide, which is very exciting. So I'm going to stop there. This is my email. Feel free to screenshot it if you are interested in participating or just want to have a conversation with me about whether it is appropriate for your child. Please shoot me an email. I'm always happy to set up. I feel like people need to be really informed before you participate in clinical trial. I will set up a one-on-one Zoom call with you and whoever you'd like to discuss it with. And happy to discuss more and answer any questions. So with that, I think I'm going to stop screen sharing so that we can see each other. And then I'm happy to answer any other questions.
Great. Thank you so much. That was really informative and very exciting. We've got a few questions in the chat, and also if people want to, unmute and ask questions themselves, that would be great too.
Would you like me to start with the ones in the chat, or?
Yeah, let's see. You can see the chat, right?
Yeah. So the first question, this is a really great question. Could this medicine impact on tumor growth? Your daughter has NF1 and Noonan due to NF growth hormone is not suitable. It can make the tumors grow. Okay. So that is very, very good question. And the answer, I'm going to give you the hopeful answer and the honest answer. Okay. So you are correct. Growth hormone is very nonspecific, right? There are growth hormone receptors on cells all throughout the body and on tumor cells. And there is reason to be concerned that growth hormone could increase the growth of tumors. Now, that's not always been shown, so I don't want to overstate it and make it scary for people, but like, in anybody with an active malignancy, growth hormone is contraindicated, right? Like we will not prescribe it. It's almost always. There are rare exceptions, okay? Vosoritide is not known to have that effect, right? It should not, there's, from a mechanism perspective, it shouldn't necessarily lead to growth of those tumors. And depending on where the tumor is, it is possible, if that same pathway is affecting growth, that it could improve. Now, huge caveats to that. Tumor, they're like, the mechanisms that lead to the growth of some of these tumors is not always understood. I'm not an oncologist. And it's hard to always know which way the pathway is working in these situations. Depending where the tumor is, Vosoritide does not, as far as we know, to an appreciable extent, get into the central nervous system. So if it's a tumor in the central nervous system, at least it shouldn't have a positive effect, but it also shouldn't have a negative effect. It doesn't really cross what's called the blood-brain barrier. So there are many people who have raised, and actually I gave a presentation at the Endocrine Society, which is one of our, trade organizations, a few years ago, presenting our initial data. And somebody in the audience said, do you think this is going to be safer, theoretically safer than growth hormone in people who are potentially predisposed to higher risk of malignancy, which can be true in certain retinopathies, again, without overstating it. And I was like, I think it could be, and they're like, because this could be great, for those groups as an alternative treatment. So I would say I'm hopeful that the answer is yes, but there's no hard data, right? And, we'll look really closely for that. I'll give you one last piece of evidence, which is there are certain humans out there, very rarely, who have had mutations that from birth leads to them having too much CNP or too much signaling through the pathway. They're very tall. They're like over 7 feet tall, as you would expect from this. And they don't have, as far as has been reported, any cancers, any increased risk of cancers. They have scoliosis and hip problems, they're super tall, but they don't have increased risk, which is not true. If you have too much growth hormone your whole life, you have acromegaly, you definitely have increased risk of cancers. So potentially yes. That was a long-winded answer. Next question was, do you know what next steps would be with the FDA? Would BioMarin potentially be able to progress that into a phase 3 study using Voxzogo, using your data. So I would say yes, potentially. Like, I think BioMarin they're a great partner and have been very interested in where this will go. We have much more data for hypochondroplasia with the 26 patients being enrolled, and I think that there is sufficient data there to show that this works as well as achondroplasia, and I think lots of people will be interested in moving that forward. I think that, as far as I know, and I do not work for them, that there are no decisions yet made about, should they move forward with the phase 3 study, but they are closely interested to see, what happens. And the only way we will be able to influence companies to go in this way is to do these initial studies, which show like, hey, here's the proof of principle, to make it work. My study was never designed to get an FDA approval for this medicine. It's just not, it's not designed, it's not big enough, it doesn't have a placebo control. But I think that if there's enough interest and enough positive results, that it could go in that direction, but it'll take a while.
So yeah, this is so interesting. Thank you. I wondered if you think that it could work in puberty as well. My son is 12.
So that's a great question.
But theoretically.
So yes, there's not a reason that it won't work in puberty. And the question actually, it's a really important one, because in some of these conditions, the growth spurt in puberty is attenuated. So you don't have as robust a growth spurt during puberty. And some of that's probably that the signaling through the growth plate is not working as well. And perhaps if we can restore that, not necessarily to normal, but if we can restore that, maybe there'll be more of a growth spurt in puberty. It's kind of, we don't know that for sure yet. All I can say about puberty is that there are a few patients in the study, not with Noonan syndrome, because they're younger still, but with some of the other conditions, who have been on the medicine for more than a year and have now entered puberty and are continuing to grow faster, right? So I hope so. The reason for this study that patients are excluded is, again, because for the proof of principle study, we need to know whether it's the medicine making them grow faster. And if you enter puberty, and this is true whenever they do any initial growth hormone studies, also, we always focus on prepubertal children, because if you enter puberty at the same time you start the medicine, you have no idea if it was just the puberty kicking in or the medicine itself. So that, unfortunately, is why children in puberty are excluded from the study currently. But
I just have one other question, which is just how long do you think it would take until this medication could be potentially approved kind of on an international basis? Roughly.
For Noonan syndrome or for rosopathy? I mean, just being totally honest, like the absolute fastest is at least 5 more years, right? Like, I mean, we would have to, at enough data, BioMarin would probably do, a phase 2 before they went to a phase 3. I mean, and then they have to execute a global phase. They haven't even started designing the studies. They have to do a phase 2, phase 3. I mean, I think 5 years is optimistic. And yeah, I think it's a long
Are there any
I'm just being honest,
any endocrinologists that you know of that are working in Europe or other countries that are interested in testing this through their own their own regulatory organizations? I don't know if that's possible.
I think that there are people who are interested. As of right now, I'll tell you, our study is the only study of Vosoritide for anything besides achondroplasia in the world. And I do not think that for any rosopathy, there will be another study anytime soon. That maybe not, I don't know. But it's not, I mean, it has to be coordinated with the company. It's a very expensive medicine. And, so I don't think that there are going to be lots of studies opening too fast, for this. So I do think it's good, but this is got to start somewhere, and drug development takes a long time, so I'm trying to move us forward as fast as we can so that we can hopefully get to those next studies.
I know we have a few other questions. Lisa.
So I was kind of dismayed about the rule out if the child has hypertrophic cardiomyopathy, because that is something that the Costello and CFC children pretty much have.
So, and the truth is, I'm hopeful actually that there might be in the next few years like new studies, and we might take that off. Okay. The reason that was started was because, like I said, when we started this study, Vosoritide wasn't approved at all, right? It was still, the data was still very limited, and we know it lowers your blood pressure. And if somebody has hypertrophic cardiomyopathy or really bad aortic stenosis, lowering their blood pressure could be dangerous for them. Now that there are hundreds and hundreds of people, who have been on it, the lowering the blood pressure really has not led to any problems, and it's been much less of a concern, but we didn't know that at the time. So I think that over time, there's going to be some loosening of the restrictions on cardiac issues. We haven't amended that yet for our protocol, but it's constantly in my thoughts about whether we should, make a change about that for us. But we haven't done that just yet, given our small numbers.
The other piece too is that Costello and CFC can develop puberty later. There's delayed puberty. So might that also, potentially down the line extend you're already doing therapies that go through puberty. So anyway.
Yeah, so there could be more years. That's definitely true, right? There could be more years of treatment. So in this study, basically, if you've had a positive response, you can keep going until you're close to growth cessation, basically until you're growing less than 1.5 centimeters a year, I think it is, or your bones have essentially fused. So there are patients could be on it for 10 years, so.
And I know a child with CFC syndrome on Viagra for her blood pressure because it's too high. So anyway.
That's true. Like in many ways, we were talking about this, that lowering blood pressure could actually be beneficial for some of the conditions as well, like as a positive side effect. So that's definitely true.
Yeah, and I just wanted to follow up, and I think there's a similar question in the chat as well. What is the age limit at which, or what would be the timing for termination of treatment with the drug? Like just in a normal person or in a person with a resopathy? When do your growth plates stop growing?
So it varies by individual, and it really depends on when you start puberty, right? So most boys by age like 15, 16 are 97, 98% done with their growth, and girls closer to 13, 14, but that depends on when you go through puberty. So there's some people who grow into college, right? Who grow 18, 19, 20, very unusual for girls, but there are boys definitely who keep growing late in high school or into college, and girls, up to 14, 15, 16, so it really depends. So there's not an absolute age, and similar with growth hormone, there's not an absolute age cutoff. It just depends on, normally we follow your growth curve, and as your growth curve starts to plateau, or that bone age x-ray, we see that your growth plates are close to being fused, that's when we would stop the medication. With any growth promoting agent, the younger you start, typically, the more impact on final height you have. So it will be better to start at a younger age, most likely.
And have you heard any reports or seen anything relating to scoliosis? That's one thing that can impact resopathy individuals.
Yeah, so we are monitoring, we're doing spine x-rays in everybody at the day they start, and then a year later. And as expected, some people have some scoliosis at baseline. So I'll tell you that for the most part, everybody who's been on it, and it's, again, small numbers, the scoliosis has not really been affected. It hasn't gotten worse. There was one patient who did not have a resopathy, as a different condition, who had scoliosis to start out with. He started growing a lot faster. And whenever you grow faster, scoliosis often worsens. So scoliosis worsened. We paused the medicine, and then he started to do some kind of scoliosis therapy. And then actually we restarted the medicine, and now his scoliosis is getting better, not worse. And he's growing faster again. So go figure. I have no idea. So there has not been at all a consistent message that scoliosis is getting worse. A number of people have had the scoliosis at baseline. When we repeated their x-ray a year later, it looks fine. It looks, it didn't get better a lot, but it didn't significantly worse. So I think it's something we're gonna have to keep an eye on, but there's no absolute, and in achondroplasia, there has not been any signal that scoliosis is worsening in those patients.
In the chat, when should we expect updated data on the other indications like hypochondroplasia?
Great. So there are no new information coming at this year's PS annual meeting, from me at least that I know of, which is this week. And for hypochondroplasia, the entire group of patients treated will have completed their 18 months of the study in September. Okay. So it will probably take us a few months then because we also have a whole bunch of samples in the freezer that we have to send to get the pharmacokinetic measurements and everything like that. So it'll probably take a few months to get everything together and analyze it. But I would say I'm hopeful by the beginning of 2024 that we will have all of the results for hypochondroplasia for the first year. The other conditions, it's all, as you saw, the numbers are very small and people are kind of trickling in, right? So like we just recruited, I think, 2 more patients with Noonan syndrome in the last few months, right? So they haven't even started, so it takes a long time. So if you know people who might be interested, if you have friends, who are not on today's call and you can share the information, honestly, just being, again, very open, the faster we enroll, the faster we have the data. So I don't know when, I don't have any anticipated deadline for sharing results. I'm going to keep updating as we can, but there's no deadline for that. Other questions, somebody asked about any significant side effects, just what I talked about, just the local skin reactions, nothing that's lasted. And that's really been the only significant side effect. And let's see. Yeah, we don't know of any impact in adulthood. There's no plan to give it into adulthood. And how does it compare with growth hormone? So that's really hard to say. Because again, we have a small number of patients and some of these are ones who were previously on growth hormone and didn't do so well on growth hormone, but that's not necessarily representative of the general population of people with Noonan syndrome who are treated with growth hormone. Some of our responses, if you kind of graph them on the typical response in Noonan syndrome, are really good, and some of them are probably closer to average. We haven't had any poor responses yet, but we have 3 people. So I don't know, growth hormone for Noonan syndrome, there have been tons of people who have been treated. So it's hard to say.
Is there any reason to suspect that it would have any effects on tissues beyond bone? Because I think
there are receptors in other tissues, so like there are receptors in the heart, like it could definitely lead to effects on other tissues, but it doesn't have the same actions. Like it doesn't, like growth hormone has effects, as was alluded to, on lean body mass, on fat, on bone in different ways, so I'm not expecting it to have those same manifestations. But I don't know, we gotta wait and see.
Great.
Olivia, I think, has a question.
Go ahead.
Yeah, sorry, it's me again. Just because with my son is on growth hormone, I've noticed like a lot of improvements, not just on height, but on like strength and even emotionally in a way. Like he just seems stronger generally, and have a lot more stamina and strength. So I just wanted, sorry if you've explained this, but I didn't quite get the answer. But would this have a similar impact potentially or not?
So I don't know is the answer. And the truth is, if you look at the data on growth hormone and like strength, so that's been shown definitely for something called Prader-Willi syndrome, that growth hormone has, where there have been real studies that look at growth hormone versus placebo and effects on lean body mass, on strength. For the other conditions, it hasn't always been shown, like it's not clear that growth hormone directly affects like muscle strength or something like that. And sometimes I think, because I hear this from patients not infrequently, oh, they're doing more, they're more coordinated, or they seem to be able to play on the playground for longer and seem stronger. And it's hard to differentiate if that's just the effect on them growing better, right? And then or if it's a direct effect on actual muscle strength and things like that. So, I don't have a good rationale to say that Vosoritide would improve muscle strength directly, but I also have had patients on Vosoritide say, oh my God, they're playing so much better now, and similar things because they're growing better. So I just don't, it's hard for me to say. And I'm honestly, eventually, if this shows promise, eventually I would be super interested to do a head-to-head trial. I don't know that any pharmaceutical company will ever let me do this, but I would be interested in seeing a head-to-head trial of Vosoritide versus growth hormone, and maybe even together, although that's a lot of shots. So, so it's possible that they could be complementary therapies, and it's not necessarily going to be a one versus the other. And it could be that for certain patients, one works better than the other,
Yeah, and I guess the question may come up at some point if individuals are taking some of the other RAS pathway inhibitors, that might end up influencing how they're feeling and whether they would not only be able to enroll in the trial, but just whether a combination would be better than the single agents. But that's a ways off, I presume.
Yeah.
Yeah, thank you, doctor. So, with achondroplasia, we saw growth hormone had a benefit, but it was kind of a bolus. It seemed to tail off as you went to years 3, 4, and 5, and that's part of the reason why it never got approved. I guess by the FDA, it did get approved in Europe. Do you see a similar dynamic with some of these other growth type disorders that you're kind of exploring, where there's a benefit for growth hormone, but it kind of it taters off? It was interesting to see your standard deviation. So it seemed like pretty stable standard deviation as you went past a year. Do you think that that will be something where Vosoritide and growth hormone could differentiate?
I think we just don't know that answer yet. I think that for achondroplasia, from what I've heard, the data shows that in Vosoritide, the growth is sustained over multiple years. And I think that our data is much too small for any other condition to make any conclusions. So I would just say we don't know yet. And I actually think the standard deviation, for some of the patients, it looked like it was continuing to improve over time. But we don't know.
Thank you.
All right. Well, I think we've had a really nice discussion, and Dr. Dauber provided his contact information, and we will include that when we post the recording on the YouTube channel. So he is still enrolling in this study, and as he said, if you know anyone or want to pass it along to friends or peers that are in this community that might be interested, please do so. All right, well,
Awesome.
We'll wrap it up for today then. Have a wonderful evening, and we'll catch you again and hopefully see you at the symposium in the future.
Thank you.
Thank you, guys. Thank you for having me.
Bye for now.